IVF in the Wellness Center. And tonight we are going to talk about a lot about PCOS and fertility. And I'm going to start by just going through a few slides to just talk about the PCOS piece, and then we'll go into the Q&A thing where people can ask whatever they want. I can't guarantee I can answer every question, but I will certainly give it my best. So I am going to get started. All righty. So I often like to start these presentations by just sharing some of the things I've heard from my patients over the years, and this is certainly just a sample because I've been caring for people with PCOS since I think the first patient I got was in February of 2000. So almost 25 years. And I started seeing women with PCOS when I was working at a large group medical practice called Harvard Vanguard Medical Associates. It had like several different name changes, but it's a large group medical practice in Boston that had a fertility department. I was working in the Department of Nutrition, and I developed a relationship with the reproductive endocrinologist because I had developed secondary infertility while I was trying to conceive my second child. Wasn't happening, so I went down the hall and I said, you folks need to check and see what's going on with me. Fortunately, I had some minor hormonal tweaking that ended at the IUI stage, had my second son, and then I had a surprise third son because I made some assumptions apparently about my fertility. But through that process, I experienced the workup and the testing, and many of the things that people go through gave me great appreciation for the physical and emotional rigor of what fertility treatment is all about. So my reproductive endocrinologist said to me after I came back from maternity leave with my third child that she wanted me to see her patients with PCOS. And I said, sure, because that's kind of personality I have. I always say, sure. And then I figure it out. And so I actually had never heard of it, didn't know anything about it. So I read a book. It's like a hardcover book called PCOS, The Hidden Epidemic by a real trailblazing physician named Samuel Thatcher, who actually, prior to passing away, he had agreed to look at my manuscript when I first wrote the first edition of my book, The PCOS Diet Plan. That book came out in 2010. And it was really something I felt like I really needed to do because this is a complex hormonal problem that a lot of people don't understand. It's certainly better now than it was in 2000 when I first started. But, you know, by just networking and trying to find people that were also familiar with PCOS at that time, I had to learn from the ground up. And so that eventually, as I said, culminated about 10 years into my care of women with PCOS, with the PCOS Diet Plan, this first edition. This is the second edition, came out in 2017. I have a lot of passion for this topic. I get really frustrated when people get told the wrong thing. I get really angry when I feel like people are treated badly by medical professionals who just even often don't fully appreciate how complex this is. So those conversations often end up with people talking about what their experience interfacing with the healthcare world is like. And I feel very fortunate to work with a group of physicians at Boston IVF who really get PCOS and really do so much to support women through this journey. But these are some things that people have mentioned to me over the years about their experience. It's not about fertility, it's about quality of life. For me, the doctor stopped acknowledging the problem when I had babies. So we know that PCOS is a genetic condition that lasts a lifetime. And women, you know, people need care ongoing beyond their reproductive years, but often I end up seeing people in the throes of the fertility treatment. The fact that we want our PCOS treated even if we aren't conceiving, trying to conceive. Lean PCOS needs nutritional counseling too, not just a prescription for metformin and birth control pills. In many ways, I feel women with what we call lean PCOS, um, in many instances, are the most ignored because people look at them and think you don't look like you have PCOS, which is, of course, we know a fallacy because PCOS comes in all shapes and sizes. But even in the healthcare world, people often just focus on people that are the most symptomatic and kind of glaze over people that don't fit that kind of template. Since losing weight can alleviate symptoms of PCOS, it would be nice to have the tools to do so. So I always encourage people, my patients, and I know that people are often interested in weight management, but I always encourage people and say, I know it can be hard, but to try not to hook the value of healthy eating and exercise to the weight loss train only, because if that train doesn't pull out of the station, people often get frustrated and they lose patience and they don't see the value in the healthy eating and exercise, which is going to make somebody a healthier person, a more fertile person, a better candidate for going into a pregnancy, no matter what somebody's weight is. Also, don't tell women that PCOS means there's no chance to have a child. Heartbreaking stuff. The number of times I've been told that women were told when they were teenagers that having PCOS meant that they might not have children. I can't think of anything crueler to say to a young girl, and it's not even true. I also want the option of traditional and natural approaches when treatment is prescribed. It's one of the reasons why the Wellness Center exists, is because the evidence was telling us that even people experiencing the fertility journey that had good odds of ultimately succeeding were dropping out simply because they couldn't handle the stress. And so to pair the very high-tech, science-y stuff of assisted reproduction with more natural approaches, nutrition, acupuncture, psychotherapy, and anything else people find helpful. I'm a big fan of nature therapy myself. Getting out in the woods. I think a lot of us came to appreciate that during the pandemic. I'm 49 and the reproductive endocrinology practice is done with me since I'm going through menopause. Again, PCOS carries some health risks of chronic diseases and just getting older and straddling the menopause transition makes the risk of chronic diseases increase in everybody. I also happen to have a skin in the game in the menopause transition because I co-authored a book called The Menopause Diet Plan with my best friend from college. They always say, write about what you know, and she and I were experiencing that transition at the time that we wrote that book. I'd like to be looked at as more than just an overweight body. Again, a lot of the really unfortunate encounters that people have had with healthcare professionals over the years. That I'm overweight because of PCOS, not because I don't eat right or exercise. Certainly having PCOS can make gaining weight more easier and losing weight more difficult. And there are several different phenotypes of this condition that some people probably experience more challenges there than others. And then truly listen. Many times I feel doctors aren't hearing the full story and they've already categorized me based off my chart. So again, the idea is to empower women and not, focus on all the bad news. But I just wanted to define the condition before we move on. Estimated to affect 6 to 18% or more of women. The reason why the statistics are so varied is because I think there's just too many people that aren't diagnosed. And so we don't really know. It could be that in certain ethnic groups, the rates of PCOS are higher. So I think this 5 million people is probably conservative. We do know that PCOS is responsible for 80% of anovulatory infertility, which accounts for about a third of all cases of infertility. The hallmarks are hyperandrogenism and chronic ovulatory dysfunction, basically either people who don't get their period because they're not ovulating or ovulate irregularly and have some signs of hyperandrogenism, either from excess hair growth in places you don't want it, in the face and the chest and the back, thinning of the hair on the crown of the head, elevated levels of testosterone or DHEA in the blood. Upwards of 70% have some degree of insulin resistance, irrespective of weight. So if someone has a higher body mass index, it's associated with more insulin resistance, but diet and lifestyle, physical activity helps regardless. I just want to say a bit about BMI. I'm not a huge fan of BMI. I think people are finally starting to recognize that this is an old metric that was done on white men like 100 years ago. So no ethnic diversity and no women. So having a BMI of at a certain number doesn't tell us anything about somebody's body composition, what their diet is like, whether they're physically active. And we certainly all know people with a higher BMI who are very physically fit and eat well, just as we know people with very low BMI. Doesn't necessarily mean people are healthy. But one really telling and kind of scary statistic is, according to the Center for Disease Control, half of women with PCOS develop prediabetes or diabetes by the age of 40. So we know that insulin resistance, which we know a lot about because in its most advanced stage causes type 2 diabetes. But we understand that insulin resistance, if we think of it like this umbrella condition under which different manifestations of that can show up, PCOS is one of them. So we're used to type 2 diabetes and PCOS, this other condition called metabolic syndrome, which is a constellation of elevated blood sugar, blood pressure, cholesterol levels. Also, this condition called non-alcoholic fatty liver disease, which actually recently underwent a name change, which I can't even remember what it is. It's something like MALDS. And just as an aside, PCOS is a badly named condition because it's named after a symptom, not a cause. So if you have polycystic appearing ovaries, it's a manifestation of what's going on behind the curtain with the hormonal abnormalities and insulin resistance. And you don't even have to have cysts on your ovaries to be diagnosed with this condition, but similar to the point of the non-alcoholic fatty liver disease, there's a real concern in the advocacy world that if they change the name of the condition to something else, people are going to get confused. And then there's been a lot of effort that's gone into educating people about PCOS. And that if you change the name, it's going to set a lot of that advocacy back to square one. On that note, September is PCOS Awareness Month. And I would strongly suggest anybody with PCOS or an interest in it, go to PCOSchallenge.org, which is a national organization that does some phenomenal stuff around PCOS advocacy. And if you go to their website, you'll see all around the country during the month of September, there are public buildings lit up teal, which is PCOS's kind of ribbon color, to try to advocate for PCOS and get people to contact their legislators. And, we need more money, we need more awareness. So although we're most used to the fertility issues related to PCOS, as I just mentioned, there's an increased risk of prediabetes and diabetes. People who enter pregnancy already with some degree of insulin resistance, whether it's PCOS or prediabetes or something else, are at an increased risk of gestational diabetes and other pregnancy complications. So it's a really important reason prior to conception to understand insulin resistance so that when you go into pregnancy, you already have a good idea of how to manage that. Because pregnancy makes women insulin resistant. So if you already have insulin resistance, your risk factor for gestational diabetes is higher. Increased risks of cardiovascular disease, high blood pressure, high cholesterol, stroke, sleep apnea. There's non-alcoholic fatty liver disease. And then a lot of emotional issues for many reasons. Depression, anxiety, rates of eating disorders are higher than average in the population of people with PCOS. So how is it diagnosed? There are 3 criteria: the National Institutes of Health, the Rotterdam criteria, the Androgen Access Society. So they all basically believe, so PCOS is disorder predominantly of androgen excess, so that's elevated testosterone, based on the presence of clinical or biochemical hyperandrogenism, elevated testosterone, combined with ovarian dysfunction, polycystic appearing ovaries, excluding other conditions that may look similar, such as Cushing syndrome, thyroid disorders, congenital adrenal hyperplasia, hyperprolactinemia. So syndromes are different than diseases. A syndrome or disease is you have to have A, B, and C, or you don't have the disease. A syndrome is we're going to rule out A, B, and C and see what's left in the bucket, and in the eyes of an experienced clinician can make the diagnosis of PCOS. PCOS can also be diagnosed in postmenopausal women who are no longer getting periods based on their history of ovulation and hyperandrogenism evidence when they were in their reproductive years. So there are, generally considered 4 different classifications of PCOS. What we're most interested, or what most people are familiar with, are A and B. So A is if somebody has an ovulatory problem, hyperandrogenism, polycystic appearing ovaries. B is the ovulatory problem, hyperandrogenism without the polycystic appearing ovaries. These 2 phenotypes of PCOS tend to be more symptomatic, more menstrual problems, higher insulin levels, more insulin resistance, risk of metabolic syndrome, and struggle more with the obesity side of this. The phenotype C is hyperandrogenism and polycystic appearing ovaries, though someone is ovulating. And so it's kind of that middle of the road severity. And D is what we would often refer to as lean PCOS. It's the mildest degree of endocrine and metabolic dysfunction, fewest symptoms. But women with lean PCOS also, studies tell us they tend to have insulin resistance. It just tends to not be as severe. So in terms of the role of the nutritionist is to clarify the role of diet and lifestyle in managing insulin resistance, weight management, counseling, and support. But again, I much prefer to come at this education from the perspective of let's learn about PCOS, let's learn about insulin resistance and focus on that. Because many people who have gone through this experience have a lot of baggage related to weight management. And sometimes as soon as you start to talk about weight management, and again, I am perfectly fine with somebody who does not want to affect their weight, but just wants to be healthier. I don't tell people what to do. But, I don't think it's a bad thing to be able to ever steer around the weight loss issue, because things that you would do to manage insulin resistance may produce a weight change anyway. So kind of dressing it up in a different outfit sometimes allows us to steer around some of the old baggage. It does require education around diabetes, heart healthy eating, gestational diabetes. One of the real gifts of the pandemic and telemedicine is I've now been able to follow a number of my patients who have conceived and support them all through their pregnancy, and they have healthy pregnancies and average size babies, and all goes well when people are supported. Disordered eating, as I mentioned, when includes binge eating, can be as high as 80%. People often say they never feel full. I do want to differentiate, though, between binge eating disorder and sometimes people feel like they just eat more than they wish they did. And it could be because of the insulin resistance, about this feeling of never feeling full. In my mind, that's not the same as, a diagnosed binge eating disorder, though those certainly occur in women with PCOS. Not surprisingly, poor self-esteem, loss of feminine identity. And then, I often discuss fertility nutrition as part of that. We're not going to go through this in a lot of detail, but I just want to basically say, what are we trying to influence with diet and lifestyle and someone trying to learn more about PCOS? So this right here is reproductive endocrinology in women. This is the hypothalamic pituitary ovarian axis, which basically in a nutshell, our ovaries were born with like 2 million eggs in our ovaries. And they kind of sit there dormant until puberty, when the hypothalamus and the pituitary start signaling the ovaries to, each month, a clump of eggs, in these follicles start to mature, with the idea of 2 to 3 months down the road, at least one of those eggs will make it to maturity, kind of over the finish line, and be genetically healthy and ready for fertilization. So that piece of the journey right up to maturity, we call the preconception phase. So that 2 to 3 months prior to conception is a real opportunity to advance some of these concepts around nutrition. So this endocrinology, though, can be influenced by other endocrinology going on in the body. So our primary endocrine systems are reproductive endocrinology. In men, by the way, this is called the hypothalamic pituitary testicular axis. There's blood glucose regulation, there's the thyroid, there are adrenal glands that are responsible for our stress response. Those sit on top of our kidneys. And there are hormones that affect our gut, hormones that affect our brain. They're all on, regularly interacting with each other, but sometimes they can collide. And to the degree that we believe diet and lifestyle can make a difference, it's to manage insulin resistance that affects blood glucose regulation, because that results in excess production of insulin in order to regulate your blood sugar. Insulin is the most abundant hormone in the body, and if it's circulating at higher levels, it can throw a wrench into this hormone communication, either by interrupting it and creating a state of anovulation, not ovulating, or just noodling around within enough that people's periods are irregular. And excess insulin is also not great for egg quality. So anything we do to manage insulin resistance has the ability to potentially affect more than one aspect of fertility. So what's the best diet therapy? So there is no one identified diet to follow. And many of the studies tend to be small, but they are improving. So relative to when I first started looking at the research, the studies were like 10 people, 15 people, maybe 30. Now we're getting much larger numbers. But generally speaking, whatever helps to manage the insulin resistance, to modify hormones, promote a weight change if that's part of the goal, support fertility, prevent diabetes, that's generally going to be plant-based eating. Plant-based eating does not mean you have to be a vegetarian or vegan. It basically means you want about a third of your plate or less to come from healthy sources of protein: poultry, seafood, low-fat dairy, lean meat is okay in moderation. Plant sources of protein like beans and tofu and quinoa, nuts and seeds, and then the remaining part of the plate to be fruits, vegetables, whole grains. And yes, you don't have to fully get rid of carbs. So it's generally a lower carbohydrate. I would call like a moderate carbohydrate diet, somewhere between 40 and 45% of the calories. Higher protein, because it helps people to feel fuller longer. Protein slows down the rate at which food goes out of your stomach and into your intestines. Extra protein is also super important. If someone is trying to lose body fat, in order to prevent muscle from being lost at the same time, you have to eat more protein regularly over the day, and you need to strength train. But generally, research does support, curbing carbohydrates, focusing on less refined carbohydrates, spreading them out over the day, eating a little more protein and some healthy fats as ways to help possibly support weight management and improve metabolic issues like blood sugar, blood pressure. And as I just said, protein and fat are more satiating or satisfying than carbohydrates, so that just makes you feel fuller longer, and that's the key to portion control. Protein also, insulin is somewhat involved in the metabolism of protein, but not anywhere near as much as it is with carbohydrates. Dietary fat does not trigger an insulin response. But this does not mean that you need to follow a high protein, low carb diet, which may be high in animal fat, promote binge eating due to low blood sugar from over restricting the carbs, and is not safe or healthy for the long run and unsustainable. We do not recommend over restriction. I've been doing this for 37 years. I've seen countless people follow an over restrictive diet that they cannot stand eventually for one more minute, gravitate back to square one because the approach wasn't sustainable, and then have their weights come back to where they started. So anything that someone comes up with is really important. It's something that you can live with and sustain. And that's going to be more of a plant-based approach. Vegetables, fruits, legumes, including soy foods, are actually good for fertility. Soy foods are not damaging or dangerous. They don't disrupt your hormones. Whole grains, over refined grains as often as you can, nuts, nut butters, and seeds, more poultry, more seafood, more plant-based protein, less red meat. I would encourage people to minimize processed meat consumption. So I also work part-time at Dana-Farber Cancer Institute in Boston, and processed meat, which is bacon and sausages and the red cold cuts, ham, salami, mortadella, all of those things, consistently, regular consumption of that consistently associates with an increased risk of colorectal cancer, which we're starting to see increased risks of in younger and younger people. So those things, as I always say here in Boston, I don't care what you do when you go to Fenway Park, once a year, get a Fenway Frank and enjoy it. But for regular use, I do discourage people from eating things like bacon and sausages. Physical activity can't be understated. When we're physically active, there are proteins that are generated in our cells that assist insulin in lowering your blood sugar. So the more physically active someone is, the less insulin their pancreas has to secrete to regulate the blood sugar. Also, when your muscles are flexing, they're pulling glucose out of your blood without even needing insulin. All right, so that's just kind of a brief kind of summary type thing of PCOS. So I am going to go to the Q&A thing now and see what we have here. What myths do I find most interesting when it comes to PCOS? That you can't eat gluten and you can't eat dairy and you can't eat soy. It's not true. There's no evidence to back that up. So just because someone has PCOS doesn't mean they couldn't also have celiac disease, or they may also have gluten sensitivity or a wheat sensitivity. But what I do see a lot, and I have seen a lot over the last few decades, is people eating a lot of processed carbs and refined food, and then they go gluten-free and they take all that highly processed food out of their diet and they feel better and they feel like it's got to be gluten, when really the much more likely thing is you took a lot of highly processed food out of your diet, which makes people feel better. I'm following your suggestions for splitting carbs up during the day, but I'm gaining weight. Do I have any suggestions? So it's just so hard to that's a hard question to answer without knowing the whole big picture. Because weight management, everybody knows it's challenging, it's difficult. In the end, calories do matter. So spreading out the carbohydrates, pairing them with protein, eating more vegetables and whole fruits, and regular physical activity, including at least 2 to 3 episodes of strength training a week. Somewhere in there, people eventually have to find where the balance is that's going to promote a weight loss. But in the end, calories do matter. So even if we're kind of following the basic principles, if the total calories for the day are exceeding what's going out, then it's hard to see a weight change. But I would have to get more into the weeds with somebody's individual situation to kind of see where things might be tipping or not balancing out. Sometimes, if people don't have a history of disordered eating, they can log their food for a few days to see if what they think they're eating and what they're really eating are close, because I will tell you, we are not good judges of calorie intake. Not regular people, not dietitians, not any of us. I remember years ago reading a study where they took people and they controlled everything that they ate in a lab, and then they asked them, how many calories do you think you eat? And the average person was off by 800 calories. So it's not built into our DNA to be very good at noticing everything we eat and being very accurate at estimating foods. Interestingly, in this group, there was also a group of dietitians who were also way off. So not as off as most people, but still were underestimating calories. What medications do you put PCOS patients on well-advanced fertility? I'm not a physician, so I don't put people on medications. I can tell you that they often use metformin. I will also say, though, that I very frequently recommend people take inositol, because they've done studies comparing metformin and inositol at effectiveness for inducing ovulation in women with PCOS, and actually find that they compete really well with each other. Some studies even finding the inositol that works better. So my preference is a product that has 40-to-1 ratio of myo-inositol to D-chiroinositol at a dose of 2,000 milligrams of myo, 50 milligrams of D twice a day. Do I use AI software in the clinic? I do not. I am too much of a dinosaur. I noodled around with it. I'm not sure what the function would be, though. How do we find cyst in this disorder? Is it a functioning follicle dysfunction? Yeah, it's not really again, this is kind of a physician question, but my understanding is they're not cysts like, my sister's friend had a cyst the size of a grapefruit on her ovary. It's not those kinds of cysts. They're follicles with eggs in them that kind of started down the pipeline towards maturity, but never made it all the way through to the end before the maturation got abrupted and ovulation doesn't happen. So then another one tries, another one tries, another one tries. So it's sort of a traffic jam in a way of follicles that start the journey but never get off the highway. How do you go about getting a PCOS diagnosis? I would find a physician that you feel is versed in this. So OBGYNs, primary care doctors, reproductive endocrinologists for sure. Many reproductive endocrinologists don't see patients with PCOS who are not actively trying to conceive, but some do. So, and if you're not satisfied or you don't feel like somebody's listening to you, then go find another doctor. It's really important to be heard when you have this condition. I always encourage people when you go into a medical appointment, go in with your notes and maybe even 2 copies so that you can facilitate the conversation. And, physicians never have enough time to speak with people. So the more you go in with like fleshed out details of your history and what you've tried and what you're doing and what your family history is and what your goals are, it can be intimidating, but to prepare well for a medical appointment and then get a feel for the provider to see, is this something that you diagnose regularly and are very versed in, because that's really what you're looking for and is a good fit. How do you interpret a patient as elevated DHEA but normal, slightly low testosterone levels? Yeah, again, this is kind of, endocrinology is complicated, and this is kind of more of a reproductive endocrinology question. What I can tell you is DHEA is an androgen. It's like a hormone precursor, and DHEA in the body is supposed to convert to DHEAS, which is not, it's not the form that elevates testosterone. So sometimes you'll see DHEAS on the readout. DHEAS is not the type that produces symptoms of PCOS. But again, I always tread lightly on some of these kinds of questions that are really more for a reproductive endocrinologist. Does anyone doctor at Boston IVF expect? They all do, because PCOS is responsible for 30% of all cases of infertility, at least, probably. So they all treat patients with PCOS. I just missed something. Thoughts on inositol supplements? I love Ovasitol. I recommend it all the time. It's a great company. It's a great product. It's in that 2,000 milligram myo to 50 milligram D-chiroinositol ratio in a powdered form that is tasteless, that you mix in with any kind of liquid, just nothing with like bubbles in it, no seltzer. And they are price competitive. They are third party, analyzed by NSF, which is an independent lab. So people may know that dietary supplements are not regulated in this country, which is really a shame. There's actually laws preventing them from being regulated. So if a supplement manufacturer believes enough in their product, and I'm sure it costs something, so I'm sure that's a potential obstacle, but if they believe enough in their product to send it out to an outside lab and have it analyzed and verified that what they say is in there, then that means a lot to me. A lot of times on supplement labels, they may use some kind of sparkly language about quality control, internal this, and gluten-free and cage-free or whatever. It doesn't necessarily mean it's been independently vetted. So I really like Theralogics and I really like Ovasitol. I would take it twice a day if people are trying to conceive in particular. If I've diagnosed PCOS, can I access nutritional counseling through Boston IVF, even if my husband and I have chosen to? Yes, you can. I'm on both sides of the fence, so that's an option. What do you recommend for breakdown of cardio versus strength training for PCOS patients? So I think the recommendations for PCOS patients are similar to the general public, which would be at least 150 minutes of cardio, walking, jogging, swimming, cycling, at least 150 minutes a week. Now, 150 minutes, so that could be 30 minutes, 5 days a week, may or may not be enough to promote a weight loss. So to reduce weight, may require closer to 300 minutes a week. But I can't emphasize enough the importance of strength training. Very few of us have jobs where we're lifting or dragging or pulling or hacking things anymore. Just the Amazon people that run up and down the stairs all day long. Probably the only people that have, strengthening, or construction workers. In order to maintain muscle mass, you have to use it. We reach our peak muscle mass around our mid to late 30s, and then there's a progressive slide that slows your metabolism down over time if we're not pushing on our muscles. But remember what I said before, you need to flex your muscles. When you're flexing your muscles, it's sucking glucose out of your blood without even needing insulin. Insulin is a reproductive hormone disrupting hormone. So anything that we can do to lower circulating insulin levels by, focusing on those healthy carbs, spreading them out over the day, doing that cardio, building and maintaining muscles by eating enough protein over the day, and strength training 2 to 3 times a week. All of that in addition to metformin, ovasitol, whatever. But the exercise piece is critical. It is not true that women with PCOS can't do high intensity strength training because it'll raise your cortisol levels. It's like a baloney. Not all women with PCOS have high cortisol levels. And talk about a way to, rain on somebody's preferred way of being active if what they like to do is something at a higher intensity. So if you were going through a stim cycle, they don't want you jumping around and doing aggressive things. That's different. The only time exercise, may be detrimental is if somebody's exercising a ton and not eating enough to support it. That can create a situation called hypothalamic amenorrhea, which is another lifestyle-related infertility problem where the body has decided there's so many calories going out through all this activity, you're not eating enough, I'm going to shut down your reproductive function because I don't think it's safe for you to get pregnant. So what they have to do is dial the exercise way back and crank up the calories until their periods return. What about dairy for PCOS? Again, there's no science that says women with PCOS can't eat dairy. There isn't any. So the one time I might suggest somebody not eat dairy for a while is if part of this symptomology is bad cystic acne. So that's not just PCOS. There's some limited research to suggest severe acne may respond to staying away from dairy, but that is not specifically related to PCOS. Can you talk about how often to eat throughout the day? Secondly, you can talk about how to identify the fullness when you don't feel it. So how often someone should eat depends upon how often do they need to eat in order to not be starved the next time they approach the next meal or snack. That is often going to be dictated by what are you eating? Because if we eat a lot of refined carbohydrates, you want to think about refined carbohydrates as partially digested. There's that much less work your body's going to have to do on the inside to finish off the digestion and raise your blood sugar. And where your blood sugar goes, your insulin goes. Blood sugars that shoot up due to added sugars or a lot of refined carbs, the insulin tends to knock your blood sugar down. And that's when I'm hungry again, I'm not feeling full. So our best bet is to try to eat, not throw all the carbs out, but go for the unrefined ones. So whole grains, oatmeal, whole grain breads, brown rice, quinoa, mullet, barley, amaranth, bulgur, all of these things retain their fiber. Dietary fiber, humans can't digest because we're not goats and cows. We're not ruminant animals. So during digestion, we have to sort of sift through those fibers and untangle the glucose from the fiber, and then the fiber stays behind, swoops through your system, feeds your microbiome, which is the healthy mostly bacteria, healthy microbes that are in our gut. We call those probiotics. The probiotics need prebiotics to survive. Prebiotics are found in plant foods. So high fiber diets are great for your gut, which is great for every aspect of your health, because our immune system, we now understand, is responsible for neutralizing oxidation, neutralizing inflammation. There are elements of inflammation in PCOS. And this microbiome, the byproduct of them breaking down their prebiotics, these fibers and other elements, provides about 70% of our immunity. So healthy carbohydrates paired with enough protein. So if you say to yourself, you know, I'm going to try to eat at least 20 to 25 grams of protein with each meal, with a goal of, for most people, at baseline, we'll need probably at least 70 grams of protein, if not more, spread out over the day, paired with carbs to feel full. What I see a lot is, and this is not just in people with PCOS, but a lot of, you know, refined carbohydrate noshing over the day that just makes your blood sugar spike and drop, spike and drop, spike and drop. So in my book, I have fleshed out these visuals of these balanced plates that show you what this nutritional balance looks like, which is the best we can do to try to enhance the satiety of the things that we're eating. I also have long lists of snacks that are a combination of carbohydrates and proteins. Do you collaborate with the doctors at Boston IVF when they're treating a patient? Yes, they are my primary referral source. So yes, I do. Is coffee bad for PCOS? No. Coffee is the only time coffee is actually loaded with polyphenols, which are plant-based antioxidants. So plants contain immunochemistry, just like we have an immune system. And those plants, their immune system is designed to neutralize inflammation and oxidation and help the plants detoxify themselves. We now understand when we eat those compounds, they help us squelch inflammation and oxidation and help the body to detoxify. And coffee contains polyphenols. If you're trying to conceive, caffeine does not appear to reduce fertility. There is a concern that it may associate with a possible increase in miscarriage. So somebody who's trying to conceive should try to follow that 200 milligrams of caffeine daily put out by the March of Dimes, which is responsible for reducing birth defects. Keeping in mind that the stronger the coffee, the higher the caffeine content. Certainly if it makes you jittery and keeps you awake at night, you know, caffeine consumed after 1 o'clock in the afternoon has the ability to affect people's sleep. And getting enough sleep is critically important for managing insulin resistance and overall health. There's a sweet spot between at least 7 hours, 7 to 9 hours. Anything less or more than that tends to associate with chronic health problems and worsens insulin resistance. What's my perspective on GLP-1s and PCOS? Helpful, not helpful, not enough research? No. So this is really complicated and more than I could actually address here because it's complex. It's really complex. Those of us who are working out there with people that are on these medications, we're trying to figure out, like, under what circumstances do these look like really important and helpful drugs for people. I can tell you, if you're trying to conceive, you can't be on those medications. Everything I'm reading suggests you need to stay on them forever. I'm hearing physicians talking about giving people GLP-1s to jumpstart their weight loss efforts. I've not seen anything to suggest that's a thing. So that's about all I can say about it, because I do think it's an important category of drugs. For sure, anybody on those drugs needs to get the appropriate diet and lifestyle support, so that if for some reason they want to come off of it or they need to come off of it, they've learned about healthy eating and physical activity, which is probably the best bet anybody has at keeping off some of the lost weight. Many people recommend keto diet with PCOS. I don't believe in keto diets because I don't think they're sustainable. I don't see them as any different than any other over-restrictive diet that can't be sustained. I absolutely don't believe in these keto diets that advocate for eating a lot of red meat and coconut oil and all that stuff, because saturated fat worsens insulin resistance. What supplements do I recommend? You know, generally a multivitamin or at least vitamin D. Vitamin D deficiency, women with PCOS may be at higher risk of vitamin D deficiency. Anybody with obesity is going to be higher risk of vitamin D deficiency, as is anyone with a darker skin tone, because the same pigment in your skin that protects you from sunburns blocks UVB light, which is what you need to produce vitamin D. So vitamin D can affect fertility if people are deficient. So we just want to correct deficiencies. What types of alcohol is better to have when you have PCOS? The issue is about not types, it's equivalence. So anybody who is consuming more than one drink a day and is a woman is exceeding the health recommendations for many, many reasons. We are no longer talking about alcohol as being heart healthy or anything like that. So it's really about it's a fluid for fun, a food for fun, and the recommendation is no more than one, up to a drink a day, but increasingly researchers and health professionals are saying, please feel free to not drink every day. But a drink a day is either 5 ounces of wine, and studies tell us that people over pour wine at their kitchen table. So if it's wine is your thing, measure out 5 ounces in your glasses so you see what you have. 5 ounces of wine, a shot and a half of spirits that are 80 proof, or a shot if it's 100 proof, and a 12-ounce beer, but that's a 12-ounce. I mean, I live in the Boston area where there's a brewery on every corner. It's a 12-ounce beer that's like 4.5 to 5% alcohol. So if somebody's drinking a 16-ounce craft beer that's 7 or 8%, that's like 2 drinks. And it's calories, and it changes people's inhibitions about food choices. So there are lots of considerations. And studies tell us that women started drinking way more during the pandemic. Is not good for us. We suffer the consequences of alcohol much sooner than men do. How can you advocate for yourself if you feel like you have some symptoms of PCOS, but you're not getting much information from your doctors? It feels like nobody wants to diagnose me definitively. If you haven't seen a reproductive endocrinologist wherever you are, I would call a fertility practice and say, do you have any doctors there that will see people with PCOS if they're not trying to conceive? If you're trying to conceive, that's an in. But, I think reproductive endocrinologists, because they see so much of this, it's not to say OBGYNs and primary care doctors who choose to educate themselves a lot about this can't be very helpful. They can be, but it sounds like you're kind of hitting a wall. So you may want to look for a reproductive endocrinologist. Any suggestions to someone who does not like to eat seafood or doesn't like many veggies? So if you don't like seafood, you could take fish oil as an alternative. All I can tell you about vegetables is I say it to my kids, I say it to my patients. If you're still alive, you're not too old to keep trying fruits and vegetables, because people's taste does change over the course of their life. Something that you might not have liked earlier in life, you may like now. Something that was overcooked when you were a kid may be great, like raw or roasted or grilled. So I would say just keep trying, because these juice plus things and green powders, they are not the same as eating vegetables and fruits. Yeah, I mean, are there any research to support organic fruits and veggies due to pesticides impacting hormones? So there are concerns about chemicals in the environment being endocrine disruptors. I don't tell people you have to eat organic, because I think it's a privilege. And I know that whether or not someone is eating organic, eating more fruits and vegetables benefits your health greatly. So buy what you can afford, wash it under running water. You don't need to use rinses. Definitely don't put soap. You can make these vinegar sprays if that feels more comfortable. But, even the organizations that kind of push people to eat organic will say, if you can't afford organic, you should eat what you can afford, keeping in mind that most people are not eating the volume of fruits and vegetables that we think really can make a difference in their life. So a long-term goal of at least 2 servings of fruit, at least 3 servings of vegetables, at least 3 servings of whole grains is important if someone's really aiming for that plant-based diet. To access nutrition counseling through Boston IVF, are you able to just request an appointment? No, you don't need a referral. You can call the Wellness Center. Would you prioritize walking 10,000 steps per day or strength training 2 to 3 times a week? It's difficult to prioritize both with a traditional work schedule. I think both are important. So I would trade in some 10,000 steps for whatever it takes to put the um, strength training there. I will tell you that 10,000 steps is kind of my understanding is it's kind of a random thing that people aren't even fully clear where that number came from. Like they say it's the equivalent of 5 miles or whatever. But I've read research to suggest there's a sweet spot with health benefits at 8,000 steps. But whatever you can do, if you have to trade in some cardio time to get the strength training in there, I think they both do important things and they both need a kind of piece of the pie. I read that full fat dairy is better for PCOS than low fat because the low fat products leave more of the male hormone in the dairy. Is that accurate? I can tell you that there's research that comes from the Harvard School of Public Health on fertility, and many of those people who are going to end up reporting fertility problems will be people with PCOS. Found that consuming as little as 1 serving of full fat dairy a day seems to associate with better fertility outcomes. And there's also more research going on suggesting that the fat and dairy likely does not affect your cardiovascular risk the same as the fat that's in red meat. So again, fat is fat, it's calories. So we still have to factor in portions and all of that. But if people want to eat, serving a full fat yogurt, it's a great source of probiotics. We eat cheese, but again, portion control is key. Good app to track calories. Kind of depends. There's a lot of them out there. People with eating disorder history, I don't think should track the calories. There's MyFitnessPal. One of the shortcomings of that is that there's 94 million people constantly adding to the database, but I know people who like to use it. I have a platform I can use with my clients that I have access to because I help the company to develop it, but it's not free to the world. People who work with me, I give them access. People like the Fitbit tracker, and My Net Diary is a good one. I have heard of NAC. NAC, it's N-acetylcysteine. It can be useful in helping sensitize cells to the action of insulin. I go with inositol first. I don't use a lot of other insulin sensitizing supplements like NAC or berberine in my patient population because most of my people are trying to conceive. And if something doesn't have a clear safety data during pregnancy record, which most things will never have because people don't experiment on pregnant women, I want you to take your inositol and do your physical activity. Yes, you can use my inositol with birth control pills. I've been taking metformin and inositol for over a year. I don't feel like it's curbed my appetite. Is that odd? Any other supplements to help with infertility? Yeah, again, that's kind of a specific question. If somebody has infertility and they have egg quality issues, they may add coenzyme Q10 in there. If they're vitamin D deficient, you want to not be vitamin D deficient. Again, that's kind of specific to your case, and I can't really say more without actually having a treat more of a look. Intralipid IV. I'm used to intralipid being used in hospitals. Never heard it used in PCOS. Does lean PCOS mean you don't meet the Rotterdam criteria? Nope, because you could have irregular periods and polycystic appearing ovaries and be lean and still classify. Can you take inositol with metformin? Yes, you can take both. My understanding is they approach or try to improve insulin resistance via different pathways. Does someone with PCOS who does not get their period, will it ever come back with meds and diet? Yes, it can. Considered to be in the lean category, where do you suggest to start managing irregular cycles if my diet is relatively good? That's too specific. I couldn't say without meeting with you. Stress management. I'm a huge fan of therapy and nature therapy, getting out and walking, and acupuncture and meditation and socializing with other people, support groups, exercise. Should I do anything differently if I have lean PCOS? You know, again, just targeting, assuming the possibility of some insulin resistance. But again, I can't fully say because somebody could have lean PCOS and also be under eating, and that's why they're lean as opposed to naturally lean. Do I recommend protein powder sometimes? If somebody finds it's helpful for them to meet their protein needs. I do want people to eat food as much as possible because food is always going to require more effort from your digestive tract. Um, and elaborate on the increase of insulin resistance during pregnancy. When pregnant, is there additional efforts beyond? Yeah, so the placental hormones intentionally make the mother insulin resistant as a means of keeping more glucose in the blood to circulate around and fuel the baby's growth. So that the bigger the placenta gets, the more of these hormones are secreted. So it's generally not until like week 26 or 28 that there may be enough of these hormones secreted to make it worth doing an oral glucose tolerance test to screen for gestational diabetes. However, if you enter a pregnancy and you're already insulin resistant, I recommend people have an earlier oral glucose tolerance test in the first trimester. That's what I encourage my patients when they get pregnant to do. And I'm finding increasingly doctors are just automatically doing that. OBs are testing people earlier because the earlier you know you have elevated glucose levels in pregnancy, the safer it is for you and the baby. Do you have a recommendation women with PCOS trying to conceive like I think that's a medical question. Do I recommend cycle syncing? Nope, I don't think there's any value to it. Yes, you do have to dissolve the ovasitol in liquid. Maybe you can put it in something like oatmeal, but the one of the things I love about Theralogics is they have dietitians on staff. So you can email or call them and ask them. Gluten for PCOS, again, there's no science that says women with PCOS are more likely to be gluten sensitive, though you could have PCOS and also have celiac disease. I think green supplement powders, I don't worry about them, but they're not the same as eating fruits and vegetables. Am I established patient with Boston IVF? You can meet with me, whether it's covered or not, will depend upon your insurance. My insurance process is separate from Boston IVF. I am a provider for most of the major insurance companies in Massachusetts, but people have to contact their insurance and make sure they have coverage for nutrition counseling, and they need to check my NPI. My NPI number, it's the National Provider Identifier. If you have some to write with, it's 1-833-116-2775. 1-833-116-2775. That's how they track who can cover their patients for nutrition counseling. Do some of these diet changes ultimately come down to willpower or is medical? Yeah. So willpower, I'm of the opinion that humans are not born with a lot of willpower because it never favored human survival to not eat, don't eat. I think proactive eating, I think diet stuff, modifying not just what people are eating, but the way they're eating can make a big difference. I find it extremely common for people to undereat during the day and as a result overeat at night, which I think is not good for weight management or insulin resistance, because insulin sensitivity follows a circadian rhythm, meaning our body is more insulin sensitive earlier in the day and more insulin resistant at night. So I always say women are great dieters until about 4:30 when your brain is finally done with your restrictions. So if you don't eat enough carbs during the day, they'll come looking for you at night. I would much rather have somebody proactively eat the healthy ones there's an old saying, I don't think it has to be exactly this, but this is a pretty good match for insulin resistance. Breakfast like a king, lunch like a queen, dinner like a pauper. I don't think it has to be 100% like that, but definitely eating regularly throughout the day so your blood sugar, insulin levels are rolling, as opposed to under eating and then having it all blow up, at 5 o'clock in the afternoon. I've seen it time and time again. How do you find out if you have insulin resistance? They can test glucose levels, though glucose levels don't increase until somebody's been insulin resistant long enough that it's causing pre-diabetes. So risk factors for insulin resistance are having a BMI over 30, having PCOS, having a family history of diabetes, though you don't have to have a family history of diabetes to get diabetes. They do sometimes do fasting insulin levels, though it's not a standardized test, so people don't always agree on what's normal within, kind of the lower range. I've seen people with grossly abnormal elevated insulins, and I believe that. But what we're not sure about, like at Boston IVF, anything under 24.99 is considered normal. I've read other things to suggest lower levels in the double digits, maybe it. So, okay, I only have a few more minutes. However much tea you can drink, and try to stay with that 200 milligrams a day, but tea is much lower in caffeine than coffee. It's okay. My 41 myo-inositol D-Caro is pills. Fine. You just generally have to take like 8 pills a day. Whether you drink decaf depends upon if you've already met your caffeine 200 milligrams, then maybe you might switch to decaf. Picky eaters and healthy eating should see a registered dietitian. Prediabetes is diagnosed with either a fasting glucose, an A1C, or an oral glucose tolerance test. Is it true that PCOS is more of a barrier to getting pregnant as opposed to staying pregnant? I would say probably yes. Okay. It's 10:04, 8:04. I think I got through. Do you have thoughts on some people taking berberine? Yeah, people use berberine for insulin resistance. I think there's a role for it. I just don't use it because it doesn't have the safety data that I'm comfortable with to use if somebody were pregnant. Because if somebody's trying to conceive and they're working on their diet and lifestyle, women with PCOS can get pregnant and never get a period because periods follow an ovulation. And if you're improving your health and then you ovulate and you get pregnant, one of the major side effects in research studies that have looked at women with PCOS and weight loss and does it improve IVF outcomes, one of the major side effects is spontaneous conception. So I'm just not comfortable recommend, particularly given the lack of quality in a lot of supplements. Lavash bread, yeah, fine. Energy drinks, not a fan if they're loaded with sugar. Definitely not. And they can be very high in caffeine. Yeah, I would have to say I'm not a fan. I am not familiar with the phenomenon of background insulin resistance. All right, everybody. Thank you very much for being here. I guess I'm reading that the recording will be available within 24 hours. Joseph's flax whole wheat bread is fine. Yes. Okay. Thanks for being here. Good luck to all of you.